Good afternoon and welcome to the OR Today webinar series. We're excited to have over 250 registered attendees for today's webinar. I want to remind you today's webinar is eligible for one continuing education hour. The post-webinar survey and certificate process are now automated, so the survey link will be included in the follow-up email, which you will receive about an hour after this webinar has finished. Once you've completed the survey, you'll be able to download your certificate immediately, and one lucky attendee will win an Amazon gift card just for completing the survey. Okay, let's kick off today's webinar by giving an OR Today Live surprise pack to the attendee that can tell me the answer to the following trivia question. Today's sponsor, RepScrubs, is headquartered in Florida. What is the name of the oldest hospital in Florida? Answer now using the questions feature on your dashboard. While you're answering, I just want to remind you to save the date for our 7th annual OR Today Live Surgical Conference, which will be taking place on August the 16th to the 18th, 2020 at the Omni Interlochen Hotel, Denver, Colorado. Join us to discover new opportunities, broaden your knowledge and exchange ideas. For more information, visit ortodaylive.com. Okay, and let's see who the winner of our surprise package. It is Janet Simons. Congratulations, Janet. The correct answer is Flagler Hospital in St. Augustine. It was started in 1890. OR Today would like to thank our sponsor, RepScrubs. RepScrubs offers vendor management and cost reduction solutions. The RepScrubs program provides assurance that every vendor entering a sterile department is wearing a clean, prepackaged, disposable polypropylene scrubs dispensed on site, while shifting the expense of providing those scrubs back to the vendor. The RepScrubs system offers hospitals a unique way of improving infection prevention and adherence to regulatory guidelines, reducing costs and enabling hospitals to be better control and manage vendor access. For more information, visit RepScrubs.com. Our presenter today is Charlene Frizzera, a member of the Board of Advisors at RepScrubs. Charlene, you may begin whenever you're ready.
Great, thank you so much. So thanks for the invitation to participate in the webinar today. I'm excited to have a conversation with everyone attending about hospital-acquired infections and quality of healthcare in the Medicare program particularly. You know, I just wanted to start a little bit of a bio. So I worked at CMS for 30 years. Over 30 years, I worked about half my time in Medicare, half in Medicaid. I was the regional administrator in the Philadelphia regional office. I was the deputy administrator in the Medicare program, a Medicaid program. I was the chief operating officer at CMS when the Medicare Modernization Act was passed. And my last year and a half at CMS, I was the acting administrator until Don Berwick came. So the breadth of my experience at CMS, I think, and ending with the acting administrator job really gave me the great opportunity to see across the whole spectrum of government healthcare. So, after I left, I decided to do some consulting, and I picked some companies. Obviously, RepScrubs, one of them, approaches me to help them work on their products, or just talk about how they can have a bigger impact on healthcare. So, RepScrubs, the reason I became such a strong advocate for what they're doing is I just asked initial questions to folks once I was introduced to the RepScrub product, and even folks at CMS, I called and said, hey, did you know that when medical device representatives sell a device to a surgeon, they actually are in the operating room? And it was shocking to me how many people didn't even know that happened. And I can tell you, in all my years at CMS, I didn't know that. So I had no idea that medical device representatives actually went into the operating room. So right away, I'm like, well, that's really pretty curious. Like, why don't people know that? And then, when I really started looking at the information, that there's little, if any, control over what scrubs they actually wear into the operating room. So the passion around RepScrubs is really about education and awareness. That was number one. Number one, it's just letting people know that this actually happens in hospitals. So then I started talking to some hospital CEOs, and I said, did you know this happens? And interestingly enough, they knew. And a lot of the hospitals then said that this really happens because the surgeons want the medical device representatives in the operating room, and that the surgeons probably knew that they were not actually wearing sterilized scrubs. So it came to my after that, I'm like, well, this can't be the way it's supposed to be. Like, people have to know that this happens, and we have to do something about controlling infection, particularly in hospital operating rooms. So once we begin this discussion, once we go through these questions, say, did you know? And people say no, and then we talk about, well, how often it happens. Every single entity that we've talked to, from Joint Commission to CMS, are excited and interested in what we're finding so that they can actually participate in trying to help us raise awareness and do something about controlling hospital-acquired infections in the operating room. So the specific area is really about medical device representatives and their non-sterile garments. But we thought what would be really helpful today is talk about hospital-acquired infections in general, to go over what the big picture is. And then at the end, I'll wrap up again about the more particular RepScrub area. So on the next slide, I talk about the summary of topics. And, I'm going to go through a history, some data, some penalties, and what the future looks like. It's interesting that, infection control actually started in hospitals, and it has been, and it continues to be an incredibly important factor in the high quality of healthcare. Interestingly enough, what we've seen over time is that it has, in fact, expanded into other areas. So two things are happening generally in this area. One, there's more awareness and information and controls around reducing hospital-acquired infections, and it's spreading into other settings well beyond just the operating room in a hospital to hospitals in general. And now when we'll talk a little bit about the future plan, you'll see even into other institutional settings. So the hospital-acquired infection issue is not going away, and CMS continues to work even harder every year in trying to improve the data and trying to improve what we do to ensure the elimination goal. The goal would be obviously total elimination of hospital-acquired infections in hospitals. So on the next slide, let me start with talking a little bit about the history. So, the whole journey on hospital-acquired infections actually started in 2005. So, and I've listed here some of the chronology of some of the acts that have been passed, but the general description is that this whole discussion really started around what CMS considered avoidable things. So one example is what we called never events. So we had to actually write a regulation at CMS that said we aren't going to pay for what we called never events. And never events were things like you took out the wrong organ, you cut off the wrong limb. I mean, things that when you step back, you say it's appalling that a hospital thinks they should get paid when they made a medical mistake. But that's how it started. It really started with this discussion about how do we not pay? How do we put in penalties for things that should be avoidable? So this isn't about trying to tell hospitals how to practice medicine. It is about making sure that they do everything they can to prevent what we're calling avoidable complications. So in 2005 was the first introduction of hospital-acquired infections, and the Deficit Reduction Act was the first legislation that was passed that told us to really start taking a look at this and doing something about it. In 2008, in the Inpatient Reduction Act, again, this was just about inpatient hospital services, we identified 10 categories of conditions for which this add-on payment was eliminated. So prior to 2008, hospitals were paid DRGs, and they got an add-on payment for a DRG when the services were above and beyond what the DRG called for. So it's hard to believe now when I think about it, but back under the original DRG days, you got paid a DRG for a stay, and if something else happened, you got paid for that. Well, once we started looking into, so what is this add-on? Like, what are we paying for? We found a lot of it was really these avoidable conditions. And CMS said, we're not doing that. We are not paying you an add-on to the DRG for things that you shouldn't have done. And hospital-acquired infections was obviously one of those. So in 2008, CMS said, you can get a DRG, but if there's any avoidable infection, any avoidable interaction with the patient, we are not going to pay for the add-on. And hospital-acquired infections was the number one area that we picked. And we had 10 conditions that specified what they were and that you will not get paid extra if patients have these hospital-acquired infections. And then in 2013, so, through this period of time, CMS is collecting data. They're looking at what the infections are. They're looking at what the rates are. And in 2013, they actually added 4 additional categories to the list of 10. So now there are 14 categories of conditions for which CMS does not pay an additional payment, which means the hospital does not get reimbursed for those services. So they have to pay for those themselves. There's no reimbursement for that. Obviously, that gives hospitals a strong incentive to not have those conditions within a hospital that they don't get paid for. So the leverage that CMS has, as you can see from this little history in this first history slide, is the leverage CMS has is payment. And it is shocking how providers will immediately respond to any penalties or disincentives that CMS puts out, even though hospitals should really do everything they can to avoid hospital-acquired infections. They didn't do much until CMS actually came out and said, you will no longer get paid for those. So suddenly we start seeing a significant decrease in hospital-acquired infections. And then on the next history slide, we talk about, in October of 2014, we talk about payment. So on the first history slide, you saw 2013 was the final payment rate. We added 4 categories. In October of 2014 is when the payment actually starts taking place. And that's when we changed the name from hospital-acquired infections to hospital-acquired conditions. And this is the year that CMS actually started looking at imposing penalties and not paying the add-on payments. So it took us from 2013 final reg till about almost the end of 2014 to actually institute a payment plan. And we had very significant data that showed that post 2014 hospital-acquired infections did go down. Then in October of 2016, though, we said, well, they're going down, but we really need a bigger action plan. And hospital-acquired infections is part of a bigger national quality plan. But in that plan, and I'll talk a little bit more about it near the end, it's a 2015 base year, and there's a plan that you can find on the website that tells what the goals are for 2020. And it talks about how the government is going to continue to evolve their goal in reducing hospital-acquired infections in hospitals. And of course, we've added other settings, but particularly in the hospital setting. So the next slide, I want to talk a little bit about data. And I think what this will show us is that we still have a long way to go. So it's interesting that the penalties on payment has had some impact, but we still really have a super high rate of hospital-acquired infections, even today, given all of the work that the government has tried to do to decrease these and impose penalties on hospitals. So the first data point is anyone admitted to a hospital has a 5% chance of contracting a hospital-acquired infection. Still, even today, with all of the quality measures and all of the penalties we've put in place, there's still a 5% chance of acquiring a hospital-acquired infection. It's really interesting that even today, we're finding that some hospitals don't even do a very good job of washing their hands, even though that was a big initiative a few years ago. We're finding that isn't even really happening in hospitals. So this idea that there's still a 5% chance is scary. Anybody going into a hospital should be very afraid and very worried that there's still a chance they're going to get a hospital-acquired infection. This then leads to the length of stay for hospitals increasing by 17.6 days when they get a hospital-acquired infection. And this is particularly true with Medicare beneficiaries and chronically ill patients. So a patient that goes into a hospital already compromised with a lot of conditions and complications, when you add a hospital-acquired infection onto that condition, it's shocking how much longer it takes for hospitals to get that hospital-acquired infection under control. And this is just for patients who are already in the hospital, who have not been discharged. They're still in the hospital, and they've acquired an infection while they're in the hospital. They still stay an average of 17 days longer. And then the really shocking, which again, we try to provide awareness and education, is still 99,000 people die in hospitals from just hospital-acquired infections, more than breast cancer and prostate cancer combined. These are people who are actually in the hospital, not discharged. It's pretty amazing. The data is still pretty shocking about the possibility of getting a hospital-acquired infection. On the next data slide, I talk a little bit more about the cost. So 9.4% of inpatient costs are hospital-acquired infection related. I mean, that's 10% of inpatient costs, which are billions of dollars in this country. If we could eliminate or decrease hospital-acquired infections, that could have a significant impact in decreasing the cost of healthcare in those facilities. This does not even take into account any impact on the beneficiary that is a long-term impact because of a hospital-acquired infection. So even if you're in a hospital, you get your hospital-acquired infection taken care of, what that can do to someone's healthcare still has a long-term impact over time. So, it's not just clearing up the hospital-acquired infection, it's really what impact did that have on other compromised conditions the patient may have. Hospital-acquired infections cost the healthcare system $35 billion a year. $35 billion because hospitals did not do a good job of making sure they had sterile sites in their hospitals. And then 69% of hospital-acquired infections affect people with Medicare and Medicaid. So Medicare and Medicaid patients, 69% of those with hospital-acquired infections are Medicare and Medicaid patients. That's unbelievable that a compromised group of population of patients have an incredibly high hospital-acquired infection rate. And then the last is the hospital-acquired infections account for about $1,100 per patient admission. So hospitals don't get paid for those. So if you think about it, it's still costing us $35 billion a year, and hospitals on average wind up eating about $1,100 per patient admission. So that shows you that not paying them for the hospital-acquired infection has an impact on cost, but it really does not take care of the total cost that it takes to take care of a hospital-acquired infection over time. So in the next slide, I'm going to talk a little bit about the penalties. So I mentioned that CMS creates change when they actually change the way they pay providers. So, and it can be either rewards or penalties. In this case, CMS actually imposed penalties. And as I mentioned before, there are really two levels of penalties. So the first penalty is the one that I talked about, which is the add-on. So for hospital-acquired infections, you do not get an add-on for that patient's stay if, in fact, the patient's in the hospital longer because of one of these conditions. So this is a patient that hasn't been discharged. So they're still in the hospital. In the hospital, they get a hospital-acquired infection, so they don't get the add-on. The second penalty is a readmission penalty. And that says that if a patient is readmitted within 30 days because of a hospital-acquired infection, they don't get paid for that admission at all. So there are really two penalties that CMS has imposed on hospitals for hospital-acquired infections. And they've been somewhat effective, but as I'll explain later, we still have a lot of work to do, and CMS is still working on them. But on the next slide, I talk give a little bit of statistics about, where we are today and why we still need to do a lot of work. So I will say that hospital-acquired conditions and hospital-acquired infections are used pretty interchangeably in different documents. But when I talk about one or the other, they're basically the same. I'm talking about the same thing. So on this slide, I show that 800 hospitals had penalties. So Medicare payments were cut in federal fiscal year 2019. So far in 2019, hospital-acquired infections affected 800 hospitals. And this is the highest number of hospitals since the program was established 5 years ago. So we're still trying to figure out, so what's happening? Something is still not working when we still have more hospitals today that are getting these penalties than they did in the past. So that's a pretty shocking statistic and shows that we still really need to do more work in this area to find out what's causing these conditions to happen. On the next slide, I talk about readmissions. And again, readmissions, this statistic is broader than just hospital-acquired infections. So this readmission penalty basically says if you were readmitted within 30 days for something that happened at the hospital, it could be a variety of things, you will not get paid for the readmission. But hospital-acquired infections are still a large percentage of this readmission penalty. In the readmission penalty, every year, facilities that are in the worst performing 25% lose 1% of their Medicare payments. That's a pretty significant number for hospitals. So if you're in the lower 25% quartile hospitals, you lose 1% of your Medicaid payments. So far, the program has penalized 1,756 hospitals since it was established in 2014. So interestingly enough, the readmission penalty is working more effectively than the hospital-acquired infection add-on payment. So this shows that the readmission penalty is a much stronger financial penalty. This really hits them in the pockets much harder than the add-on does. So we're seeing a much bigger benefit from the readmission penalty stopping hospital-acquired infections than we actually are from not paying them the add-on payment. In the readmission space, 110 hospitals have been penalized in all 5 years that we've had readmission penalties. So there are still 110 hospitals in this country that continue to get readmission penalties every single year. They still get penalties. So obviously CMS is going to continue to look at those hospitals to see what's happening and why they continue to have readmissions. You know, the goal of CMS is not really to collect a lot of money on hospital-acquired conditions or readmissions. Their goal is to have none. So they really don't want to collect money, right? What they want hospitals to do a much better job at controlling infections and controlling readmissions and doing a better job of taking care of patients in hospitals today. It's not about collecting a bunch of money under the penalty. So the higher the penalties, that's not good news for CMS, right? They don't want these kind of statistics. They want these to be nothing. They want to be, you know, better quality of healthcare for patients. So nobody's proud of the numbers when we collect a lot of money. We're proud when those numbers go down and patients get better quality of care. So while the penalties, again, have had some impact, there really is so much more to be done that, you know, CMS is obviously far from finishing the journey. And again, I think what we're trying to do is help educate them on some other areas that they need to look at that they haven't maybe looked at so far in trying to figure out, so what else is causing hospital-acquired infections that we can get some controls and monitoring around. So on the next slide, I'm going to talk about the future. So what does the future look like for this particular space? So CMS and AHRQ, which is the Agency for Health Research and Quality, that agency is an agency in the Department of Health and Human Services. So it's a sister agency to CMS in HHS. And they do a ton of data collection. So CMS works with AHRQ. We would always give them things that we wanted them to give us some data and do some research on, and they produce really incredible reports. They do a lot of good statistical analysis for CMS. So CMS and AHRQ still have a very strong relationship in this area, continuing to collect data, continuing to look at penalties that we've imposed, how are they working, in addition to trying to decide what are some new categories and what are some new spaces that we really need to identify in trying to reduce hospital-acquired infections and trying to really make hospitals a safe place to get healthcare, not a scary place where you think once you get there, you're going to get sicker. So there's going to be a continued emphasis on decreasing hospital-acquired infections. Again, as I mentioned earlier, that penalty, that add-on penalty, has not really produced the results that they want. So they're going to continue to try to figure out how do we squeeze that space even more so that hospitals feel more of a financial pain in that space so that we can ensure hospital-acquired infections don't happen in a hospital. There's a revised plan, and I'll talk a little bit about that, from 20 to 25 on what the department is going to be doing about it. And then we're seeing the development of new products to reduce hospital-acquired infections, such as RepScrubs, which is dealing with a pretty specific space at the moment for medical device representatives. So we're excited that, you know, we have a new space to talk to government folks about that we think, you know, if we can get some help in standardizing it, monitoring it, putting in some new controls around that, we think we can have a pretty significant impact in reducing these conditions in hospitals. So I mentioned a little bit earlier that the plan moving forward is to expand this to other settings, not just hospitals. So in the on the CMS web, on the HHS website, actually, the plan shows that they're moving into post-acute care. They're actually moving into home health. So in an environment where the healthcare system is working and moving toward more integrated care. So let me just explain that a little bit, because I think it will help to frame how hospital-acquired infection fits into the broader category of what the government is trying to do for healthcare. So healthcare, the government is trying to really create a system where there is less hospital use, where there is more home health use. So those are the two spectrums, right? Less in a hospital, more at home. But in between, there are people and places that need to exist for people to get services that should not be done in a hospital, but cannot be done at home. So those are typically today inpatient rehab facilities, skilled nursing facilities, long-term acute care hospitals. The idea is that hospitals don't provide as many services. So people would only go to hospitals when they really need an acute care service. Many of the things that are performed in hospitals today, hopefully would be done in this middle institutional setting. And then even more people would be able to get services at home. So that integration from an inpatient setting to home is important in the system of healthcare, because they're trying to connect those things together so that they aren't siloed events, so that you can track a patient from the time they enter a hospital all the way through their journey until they get home health services or they no longer need medical care. So this plan that is dealing specifically with hospital-acquired infections and readmissions is moving to all spectrums of healthcare, because what we're finding is if they leave a hospital and they go to let's say a skilled nursing facility, and then they're readmitted to the hospital for a hospital-acquired infection, maybe the skilled nursing facility could have done something to help prevent that hospital-acquired infection. So they're trying to make every provider in this continuum more aware of what hospital-acquired infections are and how they can do a better job to prevent, to identify and or help provide care they need to take care of the hospital-acquired infection instead of sending them back to a hospital. So the long-term view, and this is from 2020 to 25, would be how do we put education, awareness, and to some degree, if appropriate, penalties in all of these healthcare settings to ensure that the patient did not have a continued impact on their healthcare because of a hospital-acquired infection that they got in a hospital. So you'll see on that website a plan that incorporates lots of settings into this journey of how to improve quality of care in healthcare, especially around hospital-acquired infections. They're going to be collecting much more data. They're going to be reviewing it much more closely and doing more analytics around it. The goal is to be able to identify future metrics and future quality indicators that we should be looking at to make sure that we, one, prevent these things from happening. So the idea is, how do you prevent a hospital-acquired infection? What do we need to make sure hospitals are doing to make sure these don't happen? If in fact they do happen, then the second question is, so what is a financial penalty in making sure that there's a disincentive to make that happen, that to make sure that hospitals are really paying super close attention to what we think is a growing phenomenon, unfortunately. This effort, though, is going to be a combined effort across many government agencies. So it's not just CMS. The reason CMS is usually the focal point is because CMS has the authority and the power to change payment, which is what really affects change in healthcare. Unfortunately, people can provide guidance, they can make suggestions, but in many instances, and especially in this hospital-acquired infection space, asking hospitals to do things, saying you should be more aware, does not have as much of an impact as it does when we start changing the way they get paid. So CMS, of all the entities, CMS actually has the most leverage to do something about it because we can change the reimbursement and the way they get paid. However, CDC, NIH, AHRQ, the department that I just talked about previously, they are all the entities that provide the data and the science and the clinical information and clinical evidence that CMS needs in order to make responsible decisions about how the payment should change. So you'll see a much more collaborative effort over the next 5 years with these entities working more together and really establishing more metrics, more goals, and with science and clinical evidence, and then CMS taking the lead in making sure that they provide the right incentives and disincentives for hospitals to actually change the way they take care of patients in the hospital setting. I want to talk a little bit now specifically about surgical site infections. So, it's shocking the surgical site infections that exist today in hospitals. So let me just give you a couple of statistics, just particular surgical site infections, which is what RepScrubs is really focused on. So a couple of things that I will say around surgical site infections. So one of them is that, in the United States, there are over 500,000 surgical representatives. These device representatives are present during 35 to 40% of all surgical procedures and 68% of all large bone orthopedic procedures. So when you look at the bigger scope of healthcare, this may not seem like a big issue in the big scope of healthcare at large, but when you look at this specific surgical site infection, those are pretty staggering numbers. That's a pretty big deal to imagine that over 500,000 surgical representatives in this country are present during 35 to 40% of surgical procedures for their devices. That's a lot of surgical sites that have no control over contaminated surgical scrubs for this particular group of people. We do get, when we talk to people, we get a lot of conversations, well, what about nurses and what about doctors? And what we say is, well, there are rules, like there are guidelines around those that hospitals should be following. There's really very little for medical device representatives. Fortunately, Association of Operating Room Nurses have actually revised their guidelines in 2010, and they actually do talk a lot about scrubs and, what is a good scrub, what's a surgically clean scrub and what isn't. What's interesting is that, even when we talk about scrubs worn by healthcare professionals at large, not just the medical devices, not just the medical device representatives, it's pretty shocking that, most of the things that even happen today for scrubs for nurses and doctors really aren't appropriate. So, there's evidence that shows that, in fact, home laundered scrubs do not get rid of all of the bacteria that they should get rid of. You really need professionally laundered scrubs. You need specific bacteria killing agents to be in the wash to kill these. Now, fortunately, most of them are low grade and they don't really they may not contribute significantly to surgical site infections, but the fact that even the minimum requirements today are not 100% safe, but even if we're assuming that's safe enough, that is not what's happening with the medical device representative. So, it's a big problem that this group of people who are in surgical sites really have little or no monitoring of the contamination on their scrubs. The single largest burden attributed to the high cost of hospital-acquired infections and the risk of quality patient incomes are surgical site infections. So they are the largest burden. And the SSIs impact over 157,000 patients. 157,000 patients are impacted by the surgical site infections, and it's a cost of about $20,000 per occurrence. So again, some pretty staggering numbers just in this one specific surgical site infection space that we're talking about in terms of RepScrubs. So, if we take from the big, let me just summarize that from the great big space, right? You've got hospital-acquired infections for all over the place for all kinds of reasons. We've had some changes in what the requirements are for hospitals and how they have to monitor and make sure that they eliminate or at least reduce hospital-acquired infections, from guidance around hand washing and some pretty simple things that operating rooms are supposed to do, to financial penalties that that are now being imposed on hospitals. And even so, you can see the numbers are not decreasing. There's still significant problems. And then when you break it down to the specific surgical site infection, those numbers are even more staggering than the general numbers overall in terms of hospital-acquired infections. So, we really do have a lot of work to do in this space. And I'll just end with a study that was done in the American Journal of Infection Control by the University of Arizona. And they actually found that following a standard 8-hour shift, 92% of scrubs worn by hospital personnel are carrying dangerous bacteria. 79% of the unwashed operating room scrubs tested were positive for these hospital-acquired infections. So it's shocking that even generally scrubs are not necessarily sterilized in a hospital setting. And as I've mentioned, the statistics for surgical site it's staggering. So I will end by saying as you can see, I'm super passionate about this subject. I mean, I think people need to be aware. We need to educate people, and we are working very hard with Joint Commission and CMS and CDC even to share information that we have so that we can actually provide awareness that this is another area of hospital-acquired infections that really does need to have some focus from the government payer space for sure. And then obviously these numbers are not just Medicare numbers. So we're hoping that if we can get government payers to pay attention to it and start putting in some standards and making some penalties, that would, of course, then follow through with commercial insurance and other insurers to impose some of the same requirements that the government, we hope, will in the future impose on trying to really make a considerable effort in trying to reduce hospital-acquired infections at large, and for us particularly surgical site infections that are continuing to increase in hospitals across the country. So I will end there, and I hope that this has been helpful and interesting, and I will turn it back over for questions.
Thank you so much, Charlene. That was extremely informative. Thank you. I had a few questions here. Are hospitals currently penalised for readmissions?
Yes, so hospitals do get penalized for readmissions. So, the way it works, CMS gathers data, and when a patient enters a hospital, they actually put information for what the conditions are that the patient has. Then when then the patient, and that form follows the patient through the hospital. Patient goes home. If the patient gets readmitted for things that were on that list when the patient was in the hospital, they do not get paid for that readmit. That's one. The other thing I will mention that's interesting that CMS does is if a patient goes from a hospital to a nursing home, if they are readmitted within 30 days for for anything, if they are readmitted to the hospital within 30 days for a readmission, both the skilled nursing facility and the hospital are penalized. So they're trying to connect that, you can't just take them from a hospital and put them in a SNF and then put them back into a hospital. They're connecting that transfer, if it's for a readmission that shouldn't have happened, they are penalized. So hospitals do receive significant penalties today for readmissions.
Okay. So what initiatives have hospitals implemented to help solve this?
Sure. So many hospitals have hospitalists. A lot of hospitals use hospitalists to review those records and to really monitor the patient better throughout the time their stay in the hospital. If they don't have hospitalists, there is someone who is tracking for sure Medicare beneficiaries' records to see what is happening over time to make sure that they can try to reduce whatever looks like it could be an emerging readmission. Believe it or not, there are actually companies now that are designing algorithms that they can use to put data in, and it will give them the chances of a readmission happening. They sort of risk analysis data based on the condition of the patient and the treatment. So hospitals are trying to find ways that they can be predictive to try to avoid it. Again, actually people reviewing the records and trying to make sure that they do follow it. Having said that, though, again, in the presentation I mentioned, even with all that, readmissions are still happening. But as I mentioned, the readmissions are decreasing because of these initiatives that hospitals are doing to try to avoid a readmission, because that's a pretty big penalty for them to get paid for no part of a stay when a patient gets readmitted. That's a pretty big financial hit. So they are working hard on trying to find ways to decrease that.
Okay, that's great. And do you think quality measures have a large impact on the bottom line?
So I think, I will say they do in some spaces. I think the downside of the quality measures are what we're measuring. So CMS develops quality measures based on the data they have. So we couldn't create a quality measure if we had no data to monitor and measure it. So in the beginning, quality measures are you just take the data you have and you develop a measure around the data. What we've done over time, and from the history you saw from 2005 to today, they're still taking that information, and they're looking at collecting more data. So each year they started collecting a little bit different data. And as that database gets stronger with more data, they continue to add quality measures. So the quality measures are limited by the data they have. It gets better, and they definitely make a difference. I mean, hospitals do get penalized by not meeting the quality measures. I think the downside we're seeing in the quality measures, though, is they may not be the right measures, but they're getting better over time as we add more quality measures and as we add more penalties for those measures. I would say industry will say that they may not be the right measures, but I will say hospitals do a lot to meet those measures because there are, again, financial penalties if you don't meet the measures. So they're working to some degree. They're not the answer to the problem yet, but as we get more data, they will become more important.
Okay, that's great. Another question is, what factors do you think contribute to HIIs?
Yeah, the factors really, I mean, it's pretty simple, actually. It's sloppiness in a hospital. I mean, it's shocking to me. So I guess it was maybe 8 or 9 years ago, probably 15 years ago, we came out with the checklist for an operating room, which said you have to wash your hands. Really? You have to give hospitals a checklist? And CMS says you have to follow the checklist to tell them to wash their hands? You got to be kidding. So it's puzzling, right? What is this? This is sloppiness. It's not having sterilized equipment. It's people taking shortcuts. It's human error. This is not healthcare. This is a real problem of people just not really being careful for what they do. The majority of the time, there's some infections that, just are impossible to stop. But generally, the majority of them, it's really just sloppy hospital control. I mean, think about what we're just talking about with the medical device representatives. Really, does anybody think it's okay for those people to go into an operating room with unsterilized scrubs? How could that be right? So it sounds simple, but that's the truth. I mean, this is really just sloppy infection control in hospitals.
Okay, that's great, Anne. And do you know what programs are in place to help penalized hospitals?
So, I don't know if you've heard of the quality improvement organizations, but CMS has been contracting with these quality improvement organizations over 20 years. And the goal of those contracts are to provide technical assistance to all kinds of industry folks and people. So there is a program, the quality improvement organizations actually do provide guidance. They actually do go into hospitals that have problems and try to help them figure out what they should do to try to alleviate them. So there is technical assistance to hospitals. The other thing that I will say, though, is until these penalties are significant enough that it really impacts the bottom line. I mean, to be fair to a hospital, how much money am I going to put into changing all this if it doesn't really make that much difference in the end in my bottom line? I mean, it's sad to say, and it sounds pretty cynical, but I'll tell you, having been outside of CMS now and working with hospitals, it really, there's always a financial calculation. How much money does it cost for me to avoid these? And is it really worth all of those efforts for the little bit of penalty that I'm going to get for for somebody having a hospital-acquired infection? But the most, and a lot, there are grades of hospital-acquired infections. Like, so some of them are pretty minor and they can fix pretty quickly. Some of them are horrible, like MRSA. Those are terrible hospital-acquired infections. The people, probably most of the people die from those sort of infections. So I think, what I'm finding is hospitals are focusing more on the what I'll call the higher level hospital-acquired infections and really trying to figure out more, how do we really control that? Because those are the ones that are just contributing to the worst quality of care. But, they aren't really that distinguishable. Bacteria is bacteria. It comes from many places. In fairness to hospitals, I think it is hard. So even if we do everything we possibly can, even if we put in place all of these controls, there will always be hospital-acquired infections, right? Things just happen that can't be controlled or stopped. But I think the goal here is to identify as many things as we possibly can that cause this. CMS provides technical assistance and guidance through the quality improvement organizations to help hospitals deal with this. And then again, there are all kinds of companies, that hospitals can hire to really do audits and reviews and really look through their hospital system to see what they can do to improve. So there's a lot of help for hospitals who are interested in figuring out what they can do to really reduce their hospital-acquired infections, from CMS to private entities that can help them figure it out.
That's great. And we've got one more question. You said most of the presentation was in reference to hospitals. Do you feel that RepScrubs would be beneficial in /4 and ASC?
Oh, absolutely. And as a matter of fact, they're actually going into ASC. So I think, and in the beginning, I mentioned that, this idea of infections in any institution is a problem. And that's why the action plan that CMS has put, that the department has put together, actually has 4 stages. So it has acute care hospitals as phase 1. Phase 2 are ambulatory surgery centers, ESRD facilities. 3rd are long-term care facilities. And then the 4th phase is what they call antibiotic stewardship. And we didn't talk about that at all today, but it's this idea that, the overuse of antibiotics in this country and how that contributes to the inability to deal with hospital-acquired infections. But it's a 4-phase plan that they have over the next 5 years that they're going to address it in all of those settings.
Okay, and we've got another interesting one coming here. Is there data to compare HAI rates in the US with other countries?
We tried to find it. We couldn't find any data. I think the problem is other countries don't identify it as hospital-acquired infections. So the categorization, we haven't had anything that was easy enough to pick. I suspect we could go through data about particular infections, but there really isn't data that fits into this nice bucket as we've defined it. So it's a little harder it's been hard for us to find anything that, is apples to apples. We take a lot of work on our part to make that comparable data.
Okay, that's great. It doesn't look like we've got any more other questions. So thank you.
I'm sorry. So this is Charlene. I just feel like, one thing I just wanted to add, I think, let me just go through, I mentioned the 2020 to 2025 goal, but let me just give you a few highlights of what that is. I think that is important for you moving forward to think about, where this is moving to. So in phase 1 is the acute care hospitals, as I mentioned, which, will be more of what we've been doing, trying to improve what we've done. There's an action plan that has 5-year goals for 7 specific measures. And it's really interesting that the reduction percentage, most of these 7 measures, they're looking for a 50% reduction by 2025. Now it's about we're saying maybe a 6% reduction per year. They're looking for a 50% reduction by 2025. So that's a very aggressive plan that in 5 years, they want to reduce these hospital-acquired infections by 50%. And that's on the hospital side. On the ambulatory surgery, the ESRD side, they're really working on incorporating what they call the outpatient environment and addressing the health and safety of healthcare workers and the risk of transmission, particularly for not only hospital-acquired infections, but influenza and other communicable diseases. So this kind of fits into a bigger quality measure, but they're looking at how do we take those facilities, what we're calling the ASCs and the ESRDs, and how do we talk about hospital-acquired infections that these patients see, and then I would say reterming it just infections that are acquired in these facilities. So they're looking for those 2 spaces as phase 2. Phase 3 is going to be long-term care facilities. Again, so trying to figure out what are infections that are happening in those facilities and how do we monitor, control, provide guidance, and eventually penalize them for having hospital-acquired infections. And then the last phase is this antibiotic stewardship, which is really talking about how do we curb the overuse of antibiotics because they're having such a significant impact in becoming, people are becoming resistant to those, and how important I find it interesting that, we're now combining, how can we help prevent them once people get them? And we're actually finding the healthcare services today maybe are are making it even harder to address these infections. So how do we look within the healthcare delivery system itself to change what's happening in terms of dealing with the hospital-acquired infections, and how do we not only prevent them from happening, but how do we address them once they have them? So I think, again, just interesting that the scope is getting much broader than it ever was before. And, you're just going to continue to see a very concerted effort on how do we really try to curb these infections that shouldn't happen.
That's great. Thank you. That's a very thought-provoking webinar today, I think. So thank you again, Charlene. That was fantastic. And thank you once again to our sponsor, RepScrubs. Just a reminder that the post-webinar survey and certificate process is now automated. So the survey link will be included in the follow-up email, which you'll receive in about an hour's time. Once you've completed the survey, you'll be able to download your certificate immediately, and one lucky attendee will win an Amazon gift card for completing the survey. If you have any questions, please contact us at webinar@mdpublishing.com. For more information on our upcoming OR Today webinars, please visit our website, ortoday.com/webinars. So thank you once again, Charlene and RepScrubs, and enjoy the rest of your day, and we hope to see you next time.
Thank you.